Did you know that diabetes, often seen as a single condition, is actually a vast, heterogeneous spectrum of disorders, quietly developing for years in many people before diagnosis? Welcome to the Deep Dive. Today, our mission is to embark on an unparalleled journey to truly master a critical area of human health, diabetes and its intricate pharmacology. We're moving beyond surface-level explanations to equip you with the depth of knowledge that sets elite professionals apart.
And that's exactly the right mindset for this topic. What's truly fascinating here is the sheer complexity and the systemic nature of the body's glucose regulation. To grasp this at a professional level, we need to uncover not just what goes wrong, but critically why it goes wrong, and then how science has ingeniously developed interventions to address these precise imbalances.
Our mission today is to take a stack of dense, expert sources on diabetes, specifically from the authoritative GOODMAN and GILMAN's The Pharmacological Basis of Therapeutics, and distill it into clear, actionable, and profoundly memorable knowledge for you. We're going to cut through the jargon, not to simplify for simplicity's sake, but to give you that shortcut to being truly well-informed, equipped to understand this condition with the depth and nuance of a seasoned expert. We're going deep. Okay, let's unpack this. We often hear the term diabetes, and it sounds like one singular disease, but our sources immediately clarify that diabetes mellitus is actually a, heterogeneous spectrum of metabolic disorders. What does that truly mean for our understanding?
It's a critical distinction, yeah. The term heterogeneous spectrum implies it's not a single disease entity, but rather a collection of conditions. This heterogeneity stems from what are likely disparate genetic predispositions interacting with various environmental factors, Despite these varied origins, they converge on a common outcome: impaired glucose homeostasis and ultimately sustained hyperglycemia or high blood sugar. For most individuals, the underlying pathogenesis is a complex interplay. It involves some combination of insufficient insulin secretion from the pancreatic beta cells, a reduced responsiveness of target tissues to the insulin that is produced, whether endogenous or exogenous, and an increased production of glucose, primarily from the liver. Furthermore, we consistently observe abnormalities in the metabolism of both fats and proteins, which only complicates the overall picture of metabolic dysregulation.
And the consequences of that persistent hyperglycemia can be truly devastating, extending far beyond acute symptoms like thirst or fatigue, right?
Precisely. While acute symptoms and metabolic abnormalities are certainly present, the major source of long-term morbidity in diabetes arises from chronic end organ damage. This damage accrues silently over years due to prolonged hyperglycemia, effectively initiating a systemic attack on various organ systems. We're talking about retinopathy, which is damage to the small blood vessels in the eyes, serving as the leading etiology of blindness in adults in the U.S.
Wow.
Then there's neuropathy, or nerve damage, which is a pervasive and often debilitating complication, representing the most common cause of non-traumatic lower extremity amputations. Nephropathy, or kidney damage, is another critical microvascular complication, standing as a major reason for renal failure requiring dialysis or kidney transplantation. And of course, cardiovascular disease impacting the heart and major blood vessels is a profound macrovascular complication, significantly increasing the risk of myocardial infarction and stroke.
So it's a profound systemic challenge, but the crucial takeaway is that these complications aren't inevitable. Our sources underscore how sustained control can significantly mitigate them.
Indeed. And this is the optimistic side of the story, really. Sustained control of blood glucose levels, meticulously maintained over time, combined with aggressive treatment of comorbidities like hypertension and dyslipidemia. Well, it can dramatically mitigate the progression and severity of these chronic complications. This comprehensive approach, involving various therapeutic options, aims to prevent that long-term insidious damage. Now, to truly master this topic, we first need to understand the fundamental physiological processes that are disrupted in diabetes. If we connect this to the bigger picture, to fully appreciate what goes wrong, we must first dive into how the body normally keeps glucose in exquisite balance.
Here's where it gets really interesting. How does our body normally maintain glucose in such a precise range? It's far more than a simple switch, isn't it? It's a highly developed systemic process involving a fascinating interplay of different organs and intricate communication networks.
Absolutely. The maintenance of glucose homeostasis is a complex symphony involving several major organs working in concert, meticulously orchestrated by hormones and neural signals. When we refer to glucose tolerance, we're speaking specifically about the body's ability to process and manage glucose after a challenge. typically measured by tests using standardized oral or intravenous glucose loads. At the absolute heart of this entire system is insulin. Its actions are of central, indispensable importance for glucose homeostasis, but insulin doesn't work in isolation.
Right.
It's supported by an intricate web of inter-organ communication involving other hormones like glucagon, a complex network of nerves, various local factors within tissues, and the availability of different energy substrates. The pancreatic beta cell, a tiny but mighty component within the islets of Langerhans, plays an absolutely essential role in normal glucose tolerance. This remarkable cell precisely adjusts the amount of insulin secreted after meals to promote glucose uptake and storage, and it also critically regulates glucose output from the liver during fasting states, ensuring a steady supply for the brain.
Okay, let's picture the fasting state. What's happening when you haven't eaten for hours, say, overnight before breakfast? How does your body fuel itself and keep the brain happy?
Right. In the fasting state, your body's primary fuel demands are met by the oxidation of fatty acids, which are abundant in stored fat. However, the brain is an outlier. It cannot effectively use fatty acids for energy. It critically relies on a continuous supply of glucose for normal function, consuming approximately 2 milligrams of glucose per kilogram of body weight per minute in adults.
Wow, that's quite a demand.
It is. So the liver becomes the primary provider of this essential fasting glucose. It does so through two main processes. First, by breaking down its own stored liver glycogen, a process called glycogenolysis. Second, and predominantly during prolonged fasting through gluconeogenesis, the de novo conversion of non-carbohydrate sources like lactate, alanine, and glycerol into glucose.
Creating new glucose, essentially.
Exactly. And this process is exquisitely regulated by pancreatic islet hormones. A decline in circulating insulin concentration during fasting is permissive for higher rates of hepatic glucose output, meaning less insulin signaling allows the liver to produce and release more glucose. Conversely, glucagon actively maintains blood glucose by strongly stimulating both hepatic gluconeogenesis and glycogenesis, essentially acting as the body's glucose alarm, ensuring your blood sugar remains stable overnight and between meals, preventing potentially dangerous drops.
Now imagine you've just enjoyed a delicious meal.
Yes.
Once the body's rapid anticipatory response to that influx of nutrients.
When you eat, the ingestion of food, the subsequent absorption of nutrients from the gut, and the resulting elevation of blood glucose concentrations all immediately stimulate insulin secretion from the beta cells. Once insulin is released into the bloodstream and activates its specific receptors on target cells, its primary role is to promote anabolism across the body. This means it orchestrates the building up of energy stores. Glucose is stored as glycogen, excess energy is converted into lipids, and amino acids are used for protein synthesis.
Building things up.
Right. So, if we distill this down, what does this all mean? The centrality of insulin is absolutely clear. All forms of human diabetes, regardless of their specific type, ultimately have as a root cause some abnormality of insulin secretion or insulin action. It is truly the indispensable hormone for maintaining precise glucose metabolism.
Let's zoom in on the pancreatic back cell, because it's truly a marvel of biological engineering. It acts as the body's most precise glucose sensor, isn't it? Almost like a finely tuned thermostat for blood sugar.
It absolutely is, and understanding its micromachinery is fundamental. Plasma glucose concentrations are the primary, exquisitely sensitive controllers of beta cell function. Elevations in blood glucose are not just a signal, they are necessary for insulin release above basal levels. Other stimuli, while important modulators, are relatively ineffective when plasma glucose is in the fasting range, typically 4.4 to 5.5 millimolars or 80 to 100 milligrams per deciliter.
Okay.
Beyond glucose, other vital stimuli include nutrient substrates like amino acids and crucial insulinotropic hormones released from the gastrointestinal tract and even the islet's own alpha cells. Autonomic neural pathways also contribute, causing some anticipatory increase in insulin secretion even before and throughout a meal. Among these stimuli, a crucial role is played by the incretins, glucose-dependent insulinotropic polypeptide, or GIP, and glucagon-like peptide-1, GLP-1. These are essential gut hormones for glucose tolerance, acting as a direct communication line from the digestive system to the pancreas.
The gut-pancreas connection.
Exactly. They are secreted in proportion to the ingested nutrient load, effectively acting as a feed-forward mechanism, relaying information to the islet to ensure an insulin response appropriate to the meal size before blood glucose peaks significantly. In healthy individuals, insulin secretion rates are highest in the early digestive phase of meals, actually preceding and limiting the peak in blood glucose. This anticipatory rapid insulin secretion is an essential feature of normal glucose tolerance.
Which is hard to replicate with therapy.
Precisely. From a clinical perspective, mimicking this precise biphasic pattern of insulin secretion is one of the key challenges for successful insulin therapy in individuals with diabetes.
And once that insulin is secreted, how does it get to work? What are its primary rapid-fire effects on glucose and metabolism, particularly in the liver and muscles?
Once released into circulation, elevated insulin concentrations primarily lower blood glucose through two potent actions. First, by inhibiting hepatic glucose production, or HGP, from the liver, and second, by stimulating the uptake and metabolism of glucose by liver, muscle, and adipose cells. These actions are exquisitely concentration dependent. For instance, hepatic glucose production is inhibited half maximally by a relatively low concentration of insulin, around 120 picomoles per liter.
So the liver is very sensitive.
Very sensitive. Glucose utilization by peripheral tissues, however, is stimulated half maximally at a higher concentration, closer to 300 picomoles per liter. The timing of these effects also varies. Insulin's impact on the liver can be quite rapid, initiating within the first 20 minutes of meal ingestion, whereas the stimulation of peripheral glucose uptake into muscle and fat may take up to an hour to reach significant rates. Insulin also has potent effects on lipid metabolism, primarily by reducing lipolysis, the breakdown of fat, from adipocytes through the inhibition of hormone-sensitive lipase. This promotes lipid storage by increasing lipoprotein lipase synthesis and facilitating adipocyte glucose uptake. In muscle and other tissues, insulin stimulates amino acid uptake and protein synthesis while inhibiting protein degradation. Even the extracellular matrix, the intricate space between the intravascular system and cells like skeletal muscle or adipocytes, plays an important role in how insulin acts and how insulin resistance can develop. What's also critically important is how glucose is regulated during exercise. While skeletal muscle glycogen, the muscle's own stored fuel, is mobilized at the onset of physical activity, the majority of the glucose required to sustain prolonged exercise actually comes from hepatic gluconeogenesis, the liver's production of new glucose.
So the liver steps up during exercise.
It does. Here, the dominant regulators of hepatic glucose production are the catecholamines, epinephrine and norepinephrine, the fight-or-flight hormones. They stimulate both glycogenolysis and gluconeogenesis, ensuring a surge of glucose. Simultaneously, they inhibit insulin secretion and enhance the release of glucagon, all contributing to an increased output of glucose from the liver to meet the energy demands of working muscles. Furthermore, catecholamines promote lipolysis, freeing up fatty acids for oxidation in exercising muscles, and providing glycerol, a byproduct of fat breakdown, as a substrate for hepatic gluconeogenesis. It's a remarkably coordinated system.
The Bile cells are just one component of the pancreatic islets. These are remarkable mini organs within the pancreas. What other cells are part of this tiny powerhouse, and how do they collectively contribute to glucose control?
Right. The pancreatic islets, despite composing only 1% to 2% of the total pancreatic volume, are indeed highly vascularized, innervated mini organs, each containing 5 distinct endocrine cell types working in close communication. We have the alpha cells, which secrete glucagon, the hormone that raises blood glucose, the beta cells, which we've been discussing, that secrete insulin, delta cells that secrete somatostatin, or SST, a universal inhibitory hormone, PP cells that secrete pancreatic polypeptide involved in appetite and digestive processes, and epsilon cells that secrete ghrelin, often known as the hunger hormone. Now let's delve into insulin itself. It's not simply secreted. It undergoes a complex, precisely regulated journey within the beta cell. Insulin is initially synthesized as a single larger polypeptide chain called preproinsulin, a molecule composed of 110 amino acids. This preproinsulin then undergoes a highly regulated, multi-step process within the beta cell, moving through the endoplasmic reticulum, the Golgi complex, and finally into specialized secretory granules. During this journey, it's first processed into proinsulin and then further cleaved into the final biologically active products, mature insulin and C-peptide. The specific chemical properties within these secretory granules are absolutely critical for both the efficient cleavage of the prohormone and for their regulated intracellular transport to the cell membrane, where they are released together by exocytosis.
So they come out together.
Exactly. What's crucial to remember is that insulin and C-peptide are co-secreted in equimolar quantities, meaning the exact same number of molecules of each are released.
And those two, insulin and C-peptide, have very different fates in the body, which surprisingly offers significant clinical utility for diagnosis and management, right?
Precisely. Insulin has a very short half-life in the bloodstream, only about 5 to 6 minutes, due to extensive hepatic clearance, meaning a large portion is filtered out by the liver on its first pass and subsequent renal filtration. C-peptide, in stark contrast, has no known physiological function or receptor, but its half-life is much longer, around 30 minutes. Critically, C-peptide undergoes minimal hepatic clearance. This difference makes measurements of peripheral C-peptide concentrations incredibly useful in clinical assessment, providing a reliable proxy for assessing endogenous beta cell secretion.
Okay.
It allows clinicians to distinguish between the body's own insulin production and insulin that has been administered externally, for example, when evaluating suspected insulin-induced hypoglycemia or determining residual beta cell function in a diabetic patient. Furthermore, the beta cell also synthesizes and secretes islet amyloid polypeptide, or IAPP, also known as amylin. This 37 amino acid peptide, co-secreted with insulin, influences gastrointestinal motility and the speed of glucose absorption. And interestingly, pramlintide, a drug used in diabetes treatment, is a synthetic mimic of IAPP's action.
This is truly the aha moment for understanding how glucose specifically triggers insulin release. It's not just a general response, but a precise, intricate chain of molecular events that acts like a biological circuit, starting with glucose getting into the cell itself, isn't it?
Yes, it's an exquisitely precise molecular dance, a masterclass in biological signal transduction. The process begins with glucose entering the beta cell. This happens primarily via a facilitative glucose transporter, predominantly GLUT1 in human beta cells, which allows glucose to move into the cell down its concentration gradient. Once inside, glucose is quickly phosphorylated by an enzyme called glucokinase, or GK, also known as hexokinase IV. This phosphorylation step is the rate-limiting step in glucose metabolism within the beta cell.
The bottleneck.
Exactly. Unlike other hexokinases, beta cell glucokinase is most active when blood glucose concentrations are between 5 to 10 millimolars, ensuring robust intracellular glucose metabolism across the physiological range from fasting to post-meal states, precisely when insulin secretion is most needed. Its unique kinetic properties allow it to act as the beta cell's glucose sensor. The glucose 6-phosphate, or G6P, produced by glucokinase activity then enters the glycolytic pathway, leading to a cascade of metabolic changes within the cell. Crucially, this pathway produces changes in NADPH levels and significantly increases the ratio of ADP to ATP, indicating a higher energy state within the cell. This elevation in ATP is the critical signal. It inhibits an ATP-sensitive potassium channel, or KATP channel, which is located on the beta cell membrane. In addition to this channel causes it to close, preventing potassium efflux and leading to the cell membrane depolarizing, becoming more positively charged inside. This heteromeric KATP channel is composed of two essential protein subunits: an inward rectifying potassium channel subunit, KIR6.2, which forms the pore, and the sulfonylurea receptor, or FUR, which is the regulatory subunit. Interestingly, mutations in components of this KATP channel are responsible for specific types of neonatal diabetes, leading to hypersecretion of insulin and thus hyperinsulinemic hypoglycemia, and also for certain forms of monogenic diabetes.
So once that electrical signal, the depolarization occurs, what's the final step that triggers the actual release of insulin from its stored vesicles?
The membrane depolarization, a direct and rapid consequence of KATP channel closure, is the immediate trigger for the next critical event. It leads to the opening of voltage-dependent Ca2 plus channels on the cell surface. This allows a rapid influx of extracellular calcium ions into the beta cell, dramatically increasing intracellular Ca2 plus concentrations. This surge in intracellular calcium is the ultimate signal that results in the exocytotic release of insulin from its preformed storage vesicles.
The final push.
Right, these intracellular events are not simply a linear chain, but are finely modulated by additional signaling pathways. Changes in cyclic AMP, or CAMP, production play a key role. G protein-coupled receptors, or GPCRs, for hormones like glucagon, GIP, and GLP-1, couple to G's proteins to stimulate adenyl cyclase, which increases 10MP and thereby enhances insulin secretion. Conversely, receptors for somatostatin, or SST, and alpha-2 adrenergic agonists couple to G proteins, which reduce cellular CAMP production and therefore inhibit insulin secretion. It's an intricate, multi-layered feedback system. Moving beyond the beta cell, the pancreatic alpha cell also plays a crucial reciprocal role by secreting glucagon. Glucagon is released most dramatically in response to hypoglycemia, or low blood sugar, but also after short periods of fasting or even after protein-containing meals, which can stimulate its release even in the absence of hypoglycemia. Glucagon biosynthesis begins with pre-proglucagon, a larger precursor molecule. This pre-proglucagon is then processed in a cell-specific fashion into several biologically active peptides, including glucagon itself, as well as glucagon-like peptide 1, GLP-1, and glucagon-like peptide 2, GLP-2.
So one precursor makes multiple hormones.
Depending on the tissue, yes. In general, glucagon and insulin secretion are exquisitely regulated reciprocally by blood glucose. Hyperglycemia stimulates insulin secretion and concurrently inhibits glucagon release, while hypoglycemia does the opposite. However, there are exceptions. For instance, the pharmacological administration of arginine and other amino acids stimulates both islet hormones, and somatostatin, as we previously noted, acts as a universal inhibitor, inhibiting the secretion of both insulin and glucagon.
So once insulin is released and flowing through the bloodstream, how does it orchestrate its widespread, powerful effects throughout the body? It's like a master metabolic controller, isn't it? Telling cells what to do with the incoming energy.
It absolutely is. The insulin receptor is truly ubiquitous, expressed on virtually all mammalian cell types. However, the tissues most critical for precise blood glucose regulation are the liver, skeletal muscle, fat, specific regions of the brain, and paradoxically, the pancreatic islet itself. Insulin's actions are generally anabolic, which means they promote the building up of complex molecules and storage of energy. Insulin signaling is critical for promoting the uptake, utilization, and storage of the major nutrients: glucose, lipids, and amino acids.
Building and storing.
Exactly. Specifically, insulin stimulates glycogenesis, which is the formation of glycogen from glucose, lipogenesis, which is the synthesis of fat, and protein synthesis. Simultaneously, it inhibits the catabolism or breakdown of these very compounds. At a cellular level, insulin operates on multiple fronts. It stimulates the transport of various substrates and ions into cells, promotes the translocation of proteins between different cellular compartments, finally regulates the action of specific enzymes by turning them on or off, and even controls gene transcription and messenger RNA translation, ultimately influencing which proteins a cell produces. The timing of these effects is also quite remarkable. Some of insulin's actions are very rapid, occurring within seconds or minutes, such as the activation of glucose and ion transport systems, or the phosphorylation or dephosphorylation of specific enzymes. Other effects manifest over a longer period, from minutes to hours to even days, such as promoting sustained protein synthesis, regulating gene transcription, and influencing cell proliferation and growth. This complex temporal profile highlights insulin's role as a versatile and potent metabolic regulator.
Let's truly go deep on the molecular communication. How does insulin actually communicate its message inside the cell once it binds to its receptor? It's far more than a simple key and lock. It's a cascade of precise enzymatic activations, right?
It's an intricate molecular symphony that begins at the cell surface. The insulin receptor itself is a highly specialized receptor tyrosine kinase, structurally and functionally similar to the insulin-like growth factor 1 receptor. Structurally, it's quite sophisticated. It's composed of linked alpha and beta subunit dimers, which are actually products of a single gene. These dimers then link via disulfide bonds to form a transmembrane heterotetramer glycoprotein consisting of two extracellular alpha subunits, which are the binding sites for insulin, and two membrane-spanning beta subunits, which contain the enzymatic tyrosine kinase domains inside the cell. The number of these receptors can vary widely across different cell types, from as few as 40 per cell on erythrocytes to as many as 300,000 per cell on highly insulin-responsive adipocytes and hepatocytes, indicating variable tissue sensitivity. The activation process is elegant. In the inactive state, the alpha subunits normally inhibit the inherent tyrosine kinase activity residing in the beta subunits. When insulin binds to the alpha subunits, it releases this inhibition, acting like a conformational switch.
Like flipping a switch.
Precisely. This allows for the transphosphorylation of one beta subunit by the other and a rapid autophosphorylation at multiple specific tyrosine sites, extending from the juxtamembrane region all the way to the intracellular tail of the receptor. This autophosphorylation is the pivotal event. It initiates the entire intracellular signaling cascade by creating docking sites for other proteins. These activated receptor sites then phosphorylate key intracellular mediators, most notably the insulin receptor substrate, or IRS, proteins, and SRC homology 2 containing protein. These phosphorylated IRS proteins then act as molecular hubs, interacting with various downstream effector molecules to amplify and extend the intricate signaling cascade throughout the cell, leading to insulin's diverse biological effects.
And that cascade ultimately leads to the crucial step of glucose transport into the cell, particularly in muscle and fat cells. How does that crucial rapid movement of glucose from the bloodstream into the cell actually work at a molecular level?
Right. A key pathway for insulin action on glucose transport, especially in skeletal muscle and adipose tissue, fundamentally depends on activating phosphatidylinositol 3 kinase, or PI3K. PI3K is recruited and activated through its direct interaction with those phosphorylated IRS proteins. Once activated, PI3K then generates phosphatidylinositol 3,4,5-phosphate trisphosphate, or PIP3, a crucial lipid second messenger. PIP3, in turn, plays a central role in regulating the localization and activity of mTOR, the mammalian target of rapamycin, and also activates a family of serotonin kinases. Among these, the specific isoform ACT2 appears to control the downstream steps that are particularly important for robust glucose uptake in skeletal muscle and adipose tissue, and for regulating glucose production in the liver. Substrates of ACT2 then coordinate the crucial translocation of GLUT4 to the plasma membrane, a complex process involving intricate actin remodeling and other membrane trafficking systems, essentially guiding these glucose transporters to the cell surface. Now let's talk specifically about GLUT4, the key player in this glucose uptake. GLUT4 is expressed predominantly in highly insulin-responsive tissues like skeletal muscle and adipose tissue. In the basal or unstimulated state, most GLUT4 actually resides intracellularly, stored away in specialized vesicles within the cell.
Hidden away.
Yeah. However, following activation of insulin receptors and the signaling cascade we just described, these GLUT4-containing vesicles are rapidly and abundantly shifted to the plasma membrane. Once integrated into the cell membrane, GLUT4 facilitates the inward transport of glucose from the circulation into the cell. Insulin signaling also has an additional important effect. It reduces GLUT4 endocytosis, which means the protein stays on the plasma membrane for a longer period, further enhancing overall glucose uptake into the cell.
Keeping the doors open longer.
Exactly. Once glucose is transported into the cells via this facilitated diffusion, it's immediately phosphorylated to glucose 6-phosphate, or G6P, by hexakinases, effectively trapping it inside the cell. Hexakinase 2-sec and specifically is found in close association with GLUT4 in skeletal and cardiac muscle and in adipose tissue. And importantly, its transcription is also regulated by insulin, ensuring coordinated metabolic response. From G6P, glucose can then take different metabolic paths. It can be isomerized to glucose 1-phosphate, or G1P, and stored as glycogen. Indeed, insulin significantly enhances glycogen synthase activity to promote this storage, or it can enter the glycolytic pathway for ATP production, fueling the cell, or enter the pentose phosphate pathway, crucial for producing NADPH and precursor molecules. Having understood normal function, let's now comprehensively explore what happens when this delicate balance is disrupted, leading to the various forms of diabetes.
When does that delicate impaired glucose homeostasis cross the line into a formal diagnosis of diabetes? It's not arbitrary. It's about specific, clinically defined thresholds that indicate significant metabolic disruption, isn't it?
That's absolutely correct. Glucose homeostasis is broadly categorized based on specific blood glucose levels, whether measured in the fasting state, after a meal, or following a standardized oral glucose challenge. We define normal glucose homeostasis as a fasting plasma glucose level less than 5.6 millimoles per liter, or 100 milligrams per deciliter. Then we identify categories of increased risk, often referred to as prediabetes. This includes impaired fasting glucose, or IFG, characterized by a fasting plasma glucose between 5.6 and 6.9 millimoles per liter, 100 to 125 milligdl.
The warning zone.
Exactly. We also have impaired glucose tolerance, or IGT, where the glucose level is between 7.8 and 11.1 millimoles per liter, 140 to 199 milligdl, 2 hours after ingesting a 75-gram liquid glucose solution during an oral glucose tolerance test. For a formal diagnosis of diabetes mellitus, the criteria are specific and designed to capture significant hyperglycemia. It's diagnosed if a person presents with classic symptoms of diabetes like increased urination, thirst, or unexplained weight loss, plus a random blood glucose concentration of 11.1 millimoles per liter, or 200 milligdl or higher. Alternatively, a fasting plasma glucose of 7.1 millimoles per liter, 126 millimoles or higher, or a 2-hour plasma glucose of 11.1 millimoles per liter, 200 milligdl or higher during an oral glucose tolerance test are diagnostic.
Okay.
Importantly, an HbA1c of 6.5% or higher is also a diagnostic criterion. It's crucial to note that in the absence of unequivocal hyperglycemia and acute metabolic decompensation, any single diagnostic criterion should ideally be confirmed by repeat testing on a different day to ensure accuracy.
And how does HbA1c, that 3-month average, fit into this diagnostic picture? Why is it such a useful and widely adopted tool?
HbA1c provides a unique and incredibly valuable measure of average glucose concentration over the prior 3 months. This is because exposure of proteins, including hemoglobin within red blood cells, to elevated glucose produces a non-enzymatic glycation of these proteins. So the HbA1c level directly reflects the average glucose concentration to which the hemoglobin has been exposed over the lifespan of the red blood cells, which is roughly 90 to 120 days.
A long-term snapshot.
Exactly. Clinically, both impaired fasting glucose and impaired glucose tolerance are significant because they portend a markedly increased risk of progressing to full-blown type 2 diabetes. Furthermore, they are independently associated with an increased risk of cardiovascular disease, highlighting the importance of early detection and intervention even at the pre-diabetes stage. To fully categorize, the American Diabetes Association and the World Health Organization recognize 4 broad categories of diabetes: type 1 diabetes, type 2 diabetes, other specific types of diabetes, which are less common forms due to specific causes, and gestational diabetes mellitus, which occurs during pregnancy. While chronic hyperglycemia is the common thread running through all these forms, the precise pathogenic mechanisms leading to each type are remarkably diverse. This comprehensive understanding underscores why a nuanced and individualized approach is so critical for effective diagnosis and management.
Given that many people with type 2 diabetes are asymptomatic at diagnosis, often for years, screening seems incredibly important for early intervention. Who should be screened according to current guidelines?
Screening is indeed incredibly important for early detection, particularly for type 2 diabetes, as asymptomatic progression is common. The American Diabetes Association recommends widespread screening for type 2 diabetes in adults with specific risk factors. This includes individuals aged more than 45 years, or those with a body mass index greater than 25 kilograms per square meter, or even greater than 23 kg/2 in persons of Asian descent, if they have at least one additional risk factor.
Okay, so age or BMI plus something else.
Exactly. These risk factors are diverse and encompass a first-degree relative with diabetes, physical inactivity, diagnosed hypertension, a low HDL cholesterol value belonging to a high-risk ethnic group. Having a history of abnormal glucose testing like IFG, IGT, or an A1C between 5.7% and 6.4%, having established cardiovascular disease, presenting with clinical features of insulin resistance, or for women, having polycystic ovary syndrome. Women who have previously had gestational diabetes mellitus are also strongly recommended for ongoing screening.
And what are the preferred methods for that screening to ensure accuracy and convenience?
For screening, fasting, plasma glucose, HbA1c, and plasma glucose after an oral glucose tolerance test are all considered equally valid and appropriate methods. However, in routine clinical practice, fasting glucose and HbA1c are used most commonly due to their convenience and lower burden on the patient. The benefits of early diagnosis and subsequent treatment of type 2 diabetes are substantial. It should significantly delay the onset and progression of diabetes-related complications and reduce the overall burden of the disease.
Makes sense. Early intervention is key.
Absolutely. Interventions at this early stage include crucial lifestyle modifications, such as dietary changes and increased physical activity, and when appropriate, pharmacological agents like metformin. It's worth noting that screening for type 1 diabetes is not currently recommended for the general population outside of a clinical trial setting, as its pathogenesis and onset differ significantly.
Type 1 diabetes is a distinct entity, accounting for a smaller but significant portion of cases. What truly underpins this autoimmune condition? It's a very different beast from type 2, isn't it?
It absolutely is a different beast. Type 1 diabetes accounts for approximately 5% to 10% of all diagnosed diabetes cases. Its fundamental root cause is an autoimmune-mediated destruction of the insulin-producing beta cells within the pancreatic islets, leading to a profound, total, or near-total deficiency of insulin. While often perceived as a childhood disease, it's crucial to understand that type 1 diabetes can occur at any age, with up to 40% of individuals developing the condition after the age of 30, a phenomenon sometimes referred to as adult-onset type 1.
LADA.
Right.
Latent autoimmune diabetes in adults.
Yes, that's often used, although sometimes LADA refers to a slower progression. But the key point is it's not just a childhood disease. Individuals with type 1 diabetes, and frequently their first-degree relatives, also have an increased prevalence of other autoimmune diseases, which often cluster together. These include autoimmune adrenal insufficiency, Graves' disease, or Hashimoto thyroiditis, pernicious anemia, vitiligo, and celiac sprue, pointing to a broader autoimmune predisposition. There is a significant genetic component to type 1 diabetes, as evidenced by a 60% to 70% concordance rate in genetically identical twins, indicating that shared genes increase susceptibility. The major genetic risk, conferring 40% to 50% of the risk, is conferred by specific HLA class II genes that encode HLA-DR and HLA-DQ molecules, which are involved in presenting antigens to immune cells. However, genetics alone aren't enough for the disease to manifest. It is thought to involve a critical interaction between this genetic susceptibility and an environmental or infectious agent. It's important to note that most individuals with type 1 diabetes, over 75%, do not have a family member with the condition, and surprisingly, the susceptibility genes themselves are actually quite common in the general non-diabetic population. This highlights the complex interplay of factors.
So how does this autoimmune attack actually progress? Is it a sudden, catastrophic event, or a more gradual, insidious process?
The pathological process is typically gradual and insidious. Genetically susceptible individuals are believed to have normal beta cell numbers until beta cell-directed autoimmunity silently develops, at which point beta cell destruction slowly begins. The precise initiating or triggering stimulus for this autoimmune process isn't definitively known, but most theories favor early life exposure to specific viruses, such as enteroviruses or other ubiquitous environmental agents that might molecularly mimic beta cell proteins or trigger an inflammatory response.
A case of mistaken identity by the immune system.
Potentially, yes. The beta cell destruction itself is primarily believed to be cell-mediated, involving cytotoxic T lymphocytes that directly attack the beta cells. There is strong evidence of infiltrating immune cells within the islets, forming an insulitis, which produce local inflammatory agents like tumor necrosis, factor alpha, interferon gamma, and interleukin-1. All of these pro-inflammatory cytokines can directly lead to beta cell dysfunction and death. This destruction unfolds over a period of months to many years, and clinical hyperglycemia, which typically leads to diagnosis, only ensues when the vast majority, usually 70% to 80% of beta cells are already destroyed. To standardize understanding, the American Diabetes Association now recognizes 3 distinct stages of type 1 diabetes. Stage 1 involves detectable autoimmunity, reflected by the presence of 2 or more autoantibodies targeting beta cell components, but with the individual still having normal glucose levels. Stage 2 progresses to autoimmunity accompanied by dysglycemia, meaning abnormal but not yet overtly diabetic glucose levels. Stage 3 is when autoimmunity presents with symptomatic hyperglycemia, which is the point of overt clinical diagnosis.
Got it. A progression.
Most patients typically report several waves of classic symptoms like polyuria, polydipsia, fatigue, and often an abrupt and significant weight loss before diagnosis. And as we touched on, some adults who phenotypically appear to have type 2 diabetes, being overweight or obese and not initially requiring insulin, may test positive for islet cell autoantibodies, suggesting autoimmune-mediated beta cell destruction. That's the LADA picture.
Type 2 diabetes, which is by far the most common form, is often called a heterogeneous syndrome. What makes it so complex and multifaceted, and how does it generally develop over time?
Type 2 diabetes is indeed best thought of as a heterogeneous syndrome of dysregulated glucose homeostasis because it's fundamentally characterized by both impaired insulin secretion from the pancreas and impaired insulin action at the tissue level, often referred to as insulin resistance. Recent analyses of large patient databases have even identified discrete clusters of patients with common demographic and clinical features. These clusters are reproducible and have been associated with specific genetic loci and diabetic complications, which really supports this model that multiple distinct pathogenic mechanisms can lead to type 2 diabetes.
So not just one pathway.
Definitely not. Overweight or obesity is an extremely common correlate, occurring in approximately 80% of affected individuals, though it's important to remember that not all obese individuals develop type 2 diabetes, and not all individuals with type 2 diabetes are obese. For the vast majority, the condition develops gradually and insidiously over many years, often progressing through an identifiable pre-diabetic stage. Fundamentally, type 2 diabetes results when there is insufficient insulin action to maintain plasma glucose levels within the minimal range. Insulin action, in this context, is a composite effect of 2 major pillars: the circulating plasma insulin concentrations, which are directly determined by the islet beta cell's function and its ability to secrete insulin, and the insulin sensitivity of key target tissues, primarily the liver, skeletal muscle, and adipose tissue.
Okay.
Critically, all these sites of regulation insulin secretion and tissue sensitivity are impaired to variable extents in patients with type 2 diabetes, leading to its complex presentation.
And there's a strong genetic predisposition here too, isn't there, making it more likely for certain families to develop it?
Yes, it's a strongly heritable condition. Individuals with a diabetic parent or sibling have about a four-fold increased risk of developing the disease, escalating to a six-fold risk if both parents have type 2 diabetes, indicating a significant familial clustering. Over 400 genetic loci have been identified through large-scale genome-wide association studies as being statistically associated with type 2 diabetes. However, the contribution of each individual locus to the overall risk is relatively small, suggesting a complex polygenic inheritance, meaning many genes contribute a little bit, rather than one or two diabetes genes. Delving deeper into the pathophysiology of type 2 diabetes, let's look at impaired beta cell function, which is a key component. In these patients, the sensitivity of the beta cell to glucose is notably impaired. This is accompanied by a significant loss of responsiveness to other crucial stimuli, such as the insulinotropic gastrointestinal hormones, incretins, and neural signaling.
So the beta cell isn't responding properly?
Exactly. The direct consequence of this impairment is delayed or insufficient insulin secretion, especially after meals, which allows for a dramatic and prolonged rise in post-meal blood glucose. It also leads to a failure to properly restrain glucose release from the liver during fasting periods. While studies on beta cell mass are not entirely definitive, some evidence suggests that the absolute mass of beta cells may also be reduced in individuals with type 2 diabetes. This progressive reduction of functional beta cell mass really explains the natural history of type 2 diabetes, where most patients require steadily increasing therapy to maintain adequate glucose control over time, eventually often necessitating insulin.
And it's not always a clear deficiency of insulin, is it? Sometimes, particularly in the early course of type 2 diabetes, you might even see elevated insulin levels. How does that fit into the picture?
That's a crucial point, and it can be quite confusing without a deep understanding. In the early course of the disease, type 2 diabetic patients can indeed sometimes have elevated levels of fasting insulin. This is a physiological response to their higher fasting glucose levels and the presence of underlying insulin resistance. The pancreas is working overtime, trying to overcome the resistance.
Try to compensate.
Precisely. Another factor contributing to apparently high insulin levels, especially in measurements, is the accumulation of increased amounts of proinsulin. Proinsulin, as we discussed, is the precursor to mature insulin. In the type 2 diabetic islet, this processing becomes inefficient. While healthy individuals typically have only 2% to 4% of their total circulating insulin as proinsulin, patients with type 2 diabetes can have as much as 10% to 20% of their measurable plasma insulin in this less effective form. Critically, proinsulin has a considerably attenuated glucose-lowering effect compared to mature insulin.
So the total number looks high, but it's not all effective insulin.
Exactly. Additionally, many diabetic patients also exhibit elevated fasting and post-meal glucagon secretion. This excess glucagon, combined with the insufficient insulin, further contributes to the hyperglycemic state, creating a dual hormonal imbalance.
Insulin resistance sounds like cells are actively ignoring insulin's messages, almost like they've become deaf to its commands. Is that the right way to conceptualize it, and how does it manifest across the body's key metabolic tissues?
Yes, that's a very intuitive and accurate way to conceptualize it. Insulin sensitivity is precisely measured by how effectively glucose is cleared from the blood in response to a fixed dose or specific plasma concentration of insulin. Insulin resistance, then, is precisely the failure of normal amounts of insulin to elicit the expected biological response in target tissues. There's considerable variability in insulin sensitivity among different cells, tissues, and individuals, influenced by many factors including age, body weight, physical activity levels, acute illness, and various medications. Critically, individuals with type 2 diabetes or impaired glucose tolerance consistently show reduced responses to insulin, which fundamentally distinguishes them from those with normal glucose tolerance. The major insulin-responsive tissues that manifest this resistance are skeletal muscle, adipose tissue, and the liver. In muscle and fat, insulin resistance typically manifests as a significant decrease in the transport of glucose from the circulation into these tissues, meaning glucose stays in the bloodstream. In adipocytes, insulin resistance also leads to increased rates of lipolysis, the breakdown of stored fats, and the uncontrolled release of fatty acids into the bloodstream,
Freeing up fats.
which can be problematic. These circulating fatty acids, in turn, can contribute to insulin resistance in other tissues, as well as lead to hepatic steatosis, or fatty liver, and dyslipidemia, or abnormal lipid profiles. Hepatic insulin resistance primarily refers to a blunted ability of insulin to suppress glucose production from the liver, although insulin-mediated glucose uptake into hepatocytes can also be impaired.
So it's not just about what's happening inside the cells, but also where the fat is stored in the body. That seems to be a key factor.
Absolutely. The sensitivity of humans to insulin's effects is inversely related to the amount of fat stored in the abdominal cavity, specifically visceral adiposity, which is the fat surrounding internal organs. More visceral fat strongly correlates with greater insulin resistance. The precise molecular mechanisms behind this complex relationship are still incompletely understood, but several theories are gaining traction. Intracellular lipids, or their metabolic byproducts, may directly impede insulin signaling within cells. Furthermore, enlarged collections of adipose tissue, particularly visceral fat, are often infiltrated with macrophages and other immune cells, transforming these depots into sites of chronic, low-grade inflammation.
Inflammation from fat tissue.
Exactly. These immune cells and adipocytes then secrete various adipocytokines, such as tumor necrosis factor alpha, interleukin-6, resistin, and retinol-binding protein 4, which can all cause systemic insulin resistance throughout the body. Lifestyle plays a huge role here, too. Sedentary individuals are inherently more insulin resistant than physically active ones, and consistent physical training can significantly improve insulin sensitivity, sometimes remarkably.
So exercise really helps.
Immensely. This activity can decrease the risk of developing diabetes and also improve glycemic control in those who already have diabetes. It's also worth noting that insulin sensitivity naturally decreases with age, making insulin resistance more common in the elderly population. At the cellular level, insulin resistance involves blunted steps in the intricate signaling cascade, from the insulin receptor tyrosine kinase activation to the crucial translocation of GLUT4 transporters to the cell surface. Though the precise molecular targets of this blunting remain a subject of intense ongoing research. While specific genetic mutations in the insulin receptor or its signaling components have been identified, they are not believed to be responsible for the widespread clinical insulin resistance seen in the vast majority of individuals with type 2 diabetes. Very rare mutations, particularly those involving the insulin-binding domains of the extracellular alpha chain, can cause very severe syndromic forms of insulin resistance, sometimes associated with lipodystrophy. Ultimately, insulin resistance stands as a major pervasive risk factor for the development and progression of type 2 diabetes. Let's also address dysregulated hepatic glucose metabolism in type 2 diabetes, which contributes significantly to the elevated blood glucose. In this condition, the liver's glucose output is excessive even in the fasting state and is inadequately suppressed after meals. This is largely attributed to the abnormal secretion of islet hormones, specifically insufficient insulin secretion combined with, paradoxically, excessive glucagon secretion.
The double whammy again.
Yes. Increased concentrations of glucagon, particularly when combined with the liver's own insulin resistance, lead to an overproduction of glucose through both gluconeogenesis and glycogenolysis, resulting in abnormally high fasting glucose concentrations. The liver itself becomes resistant to insulin action, meaning insulin's capacity to suppress hepatic glucose production and promote hepatic glucose uptake and glycogen synthesis after meals is significantly reduced. What's particularly paradoxical is that despite these ineffective insulin effects on hepatic glucose metabolism, the lipogenic or fat-producing effects of insulin in the liver remain relatively intact, and may even be accentuated by the fasting hyperinsulinemia that often accompanies insulin resistance.
Wow, so it ignores the glucose signal but still makes fat.
In a way, yes. This unchecked lipogenesis contributes to hepatic steatosis, or fatty liver, which in turn can further worsen overall insulin resistance, creating a vicious cycle of metabolic dysfunction.
Beyond the major types like type 1 and type 2, there are other, less common but equally important forms of diabetes, often tied to specific genetic factors or other chronic medical conditions. This really speaks to the heterogeneous spectrum we discussed earlier, doesn't it?
It absolutely does, highlighting the incredible diversity of etiologies for hyperglycemia. One notable category is monogenic diabetes, which refers to forms of diabetes inherited in an autosomal dominant fashion, meaning a single mutated gene from one parent is sufficient to cause the condition. These are caused by mutations in key genes involved in glucose homeostasis. These can broadly be categorized into diabetes with onset in the neonatal period, typically before 12 months of age, and monogenic diabetes presenting later in childhood or adulthood. Some forms of neonatal diabetes are caused by mutations in the sulfonylurea receptor, SUR, or its accompanying inward rectifying potassium channel, KURA 6.2, the very ATP channel we discussed earlier, or by mutations in the insulin gene itself. Beyond the first year of life, monogenic diabetes can clinically mimic either type 1 or type 2 diabetes, requiring specific genetic testing for accurate diagnosis. In other instances, children, adolescents, and young adults might present with what's known as MOAY, or maturity-onset diabetes of the young. Phenotypically, these individuals are often not obese or insulin-resistant, and may initially present with only modest hyperglycemia, often quite stable for years. The most common causes of MODY are mutations in key islet-enriched hepatocyte nuclear transcription factors like HNF1A and HNF4A, which regulate gene expression critical for beta cell function, or in glucokinase, GK, the beta cell's glucose sensor.
Okay.
While most individuals with MODY are treated similarly to those with type 2 diabetes, patients with MODY3, which is the most common monogenic form, can be remarkably effectively treated with sulfonylureas, a class of drugs normally used for type 2, highlighting the precision of genetic diagnosis for guiding therapy. Additionally, there are numerous secondary causes of diabetes. Chronic diseases of the exocrine pancreas, such as pancreatitis, pancreatectomy, neoplasia, cystic fibrosis, hemochromatosis, or fibrocalculous pancreatopathy, can directly impair insulin secretion by damaging the beta cells. Certain endocrinopathies, or disorders of the endocrine glands like acromegaly and Cushing's syndrome, cause profound insulin resistance throughout the body.
Other hormone problems causing diabetes.
Yes. Furthermore, a variety of commonly used medications can raise blood glucose or lead to diabetes over time. These include glucocorticoids, steroids, calcineurin and mTOR inhibitors, often used after organ transplantation, atypical antipsychotics, protease inhibitors used for HIV, beta-adrenergic agonists like epinephrine. Infections like congenital rubella and cytomegalovirus can also induce diabetes. There are also uncommon immune-mediated forms, such as stiff person syndrome or anti-insulin receptor antibodies. Finally, diabetes can be associated with other well-defined genetic syndromes, including Wolfram, Down, Klinefelter, Lawrence-Moon-Beetle, Prader-Willi, and Turner syndromes, as well as Friedreich ataxia, Huntington's disease, myotonic dystrophy, and porphyria. This truly highlights the wide spectrum of etiologies.
This is where the profound long-term impact of uncontrolled diabetes becomes truly devastating. What are the major complications and why do they occur on a molecular level?
The complications of diabetes can be acutely life-threatening if hyperglycemia is left untreated and severe. We're talking about severe metabolic disturbances like diabetic ketoacidosis, or DKA, which typically affects individuals with severe insulin deficiency, and the hyperglycemic hyperosmolar state, often seen in type 2 patients. These are medical emergencies requiring immediate hospitalization for urgent insulin administration, aggressive rehydration with intravenous fluids, and careful monitoring and correction of electrolytes and metabolic parameters.
Critical situations.
Absolutely. Beyond these acute events, the chronic end-organ effects of diabetes are commonly divided into microvascular and macrovascular complications, targeting small and large blood vessels, respectively. Microvascular complications are specific to diabetes and directly result from chronic damage to small blood vessels, leading to impaired blood flow and tissue dysfunction. These include retinopathy, the leading cause of blindness in adults in the U.S., nephropathy, the major reason for renal failure requiring dialysis or kidney transplantation, and neuropathy, the most common cause of non-traumatic lower extremity amputations.
Small vessel damage everywhere.
Essentially, yes. In contrast, macrovascular complications are related to accelerated atherosclerosis, the hardening and narrowing of arteries, and include severe events like myocardial infarction or heart attack and stroke. While these occur more frequently and are more severe in individuals with diabetes, they are not specific to diabetes in the way microvascular complications are. Rather, diabetes profoundly exacerbates the underlying atherosclerotic process.
So how are these mitigated, and what are the underlying mechanisms for them at the cellular and molecular levels?
Clinical trials have clearly indicated that microvascular complications can be prevented, delayed, or significantly reduced by effective and sustained glucose lowering. Increasingly, specific diabetes medications also demonstrate benefits in mitigating macrovascular complications and even renal disease progression, which is a major breakthrough.
That's huge progress.
It is. The primary determinants of these complications are the duration and severity of hyperglycemia. The precise molecular mechanisms are still being elucidated, but current understanding points to a complex interplay of detrimental processes triggered by chronic high glucose. These appear to involve epigenetic changes, alterations in gene expression without changes in DNA sequence, increased oxidative stress, dyslipidemia, the formation of advanced glycation end products, AGEs, which are harmful compounds formed when sugar molecules bind to proteins or fats, disordered sphingolipid metabolism, specifically implicated in neuropathy, and increased levels of growth factors such as VEGF-A, which contributes to abnormal blood vessel growth in retinopathy. It's important to recognize that the pathogenic processes may differ in each affected organ and are also profoundly influenced by individual genetic susceptibility, making this a highly complex and individualized area. Having comprehensively explored what diabetes is and how it manifests, let's now turn our attention to the precise strategies and tools used to manage it, the therapy.
So with all this detailed understanding of diabetes and its potential devastations, what are we ultimately trying to achieve with therapy? It's clearly more than just lowering blood sugar numbers, isn't it? It's a holistic, individualized approach.
It's precisely that, a comprehensive and individualized approach to truly master the condition. The overarching goals of therapy are multifaceted. First, to alleviate the acute uncomfortable symptoms related to hyperglycemia, such as profound fatigue, excessive urination, and unexplained weight loss, providing immediate relief. Second, and crucially, to prevent or reduce the risk of acute metabolic decompensation, like DKA or hyperglycemic hyperosmolar state, and to prevent or significantly reduce the progression of chronic and organ complications. And finally, a key patient-centered goal is to enable the individual with diabetes to conduct the normal activities of life, including regular exercise and social engagement without undue burden. Glycemic control, the cornerstone of this management, is assessed using both short-term and long-term metrics. For short-term, real-time insights, we rely on blood glucose self-monitoring, typically through capillary blood samples, or increasingly continuous glucose monitoring, or CGM. For long-term assessment, HbA1c is paramount, as it reflects average glycemic control over the prior 3 months. Fructosamine, which measures glycosylated serum proteins, provides a snapshot over the preceding 2 weeks, useful in specific scenarios.
And continuous glucose monitoring. CGM, that's truly changing the game for many patients, offering unprecedented real-time insights. What's the technology behind it, and how is it empowering patients?
CGM is indeed a rapidly evolving technology that provides near real-time tracking of interstitial glucose, which serves as a highly accurate reflection of blood glucose levels. The current technology uses a small, disposable sensor or electrode, typically inserted just under the skin, that detects a reaction between interstitial glucose and a glucose oxidase enzyme, translating that into an electrical signal.
Tiny sensor under the skin.
Yeah. This technology is being used with increasing frequency and has revolutionized the management of type 1 diabetes, and increasingly for some individuals with type 2. CGM provides incredibly detailed glycemic datasets, which are then translated into various actionable metrics. These include the ambulatory glucose profile, which gives a visual representation of glucose trends, and time in range, which quantifies the percentage of time glucose levels are within, above, or below a defined target range, is becoming a primary metric. There's also a calculated glucose management indicator based on mean glucose that correlates well with HbA1c. This empowers patients to measure their glucose throughout fasting and feeding periods, gaining immediate feedback, which they can then share with their diabetes management team to integrate this information with their diet, exercise routines, and medication adjustments. This brings us to what we call comprehensive diabetes care. This is the definition of optimal therapy that is fundamentally patient-centered and highly individualized. It involves 3 key pillars. First, robust glucose management, achieved through disciplined diet and lifestyle modifications, regular exercise, and appropriate medication. Second, the proactive and aggressive treatment of associated cardiovascular risk factors, particularly abnormalities in blood pressure and lipids. And third, the early detection and ongoing management of diabetes-related complications, including regular screening for retinopathy, neuropathy, nephropathy, cardiovascular disease, and other potential issues.
And the ADA actually provides specific, quantifiable treatment goals for these areas, offering clear targets for clinicians and patients, right?
Yes, the American Diabetes Association has meticulously recommended specific treatment goals for non-pregnant adults, which serve as crucial benchmarks. For glycemic control, the HbA1c target is typically less than 7.0%. More granular targets include preprandial capillary blood glucose, ideally between 4.4 and 7.2 millimoles per liter, 80 to 130 mg/dL. Peak postprandial capillary blood glucose should ideally be less than 10.0 millimoles per liter, 180 mg/dL. And with CGM, the time in range, specifically defined as 70 to 180 mg/dL, should be greater than 70% of the time, with optimal being less than 5% below 70 and less than 25% above 180.
Clear metrics.
Very clear. For blood pressure, the goal is generally less than 14 90 mmHg, though lower targets like less than 130/80 mmHg may be appropriate for some. Statin therapy for lipids is also highly individualized based on age and atherosclerotic cardiovascular disease, ASCVD risk. It's vital to emphasize that despite these general guidelines, these treatment goals must be highly individualized for each patient. Factors such as the patient's individual risk of hypoglycemia, their life expectancy and age, other medical conditions, duration of diabetes, and presence of advanced complications all play a significant role. Crucially, the patient's own attitude toward diabetes, their expectations, available resources, and their support systems should also be given strong consideration in setting these personalized and realistic goals.
Before we even think about medication, what are the absolutely critical non-pharmacological steps patients can take? It's about building a strong, healthy base that medications can then enhance, isn't it?
Precisely. Laying a strong non-pharmacological foundation is paramount and often the most impactful first step. All patients should receive thorough, personalized education on glucose lowering through disciplined diet, regular exercise, and appropriate medication use. In type 1 diabetes, it's critical to precisely match caloric intake and carbohydrate counting with insulin dosing for optimal glucose control. For type 2 diabetes, lifestyle measures are primarily directed at sustained weight loss, where indicated, and the reduction of blood pressure and overall atherosclerotic risk.
Lifestyle is huge for type 2.
It's foundational. There's now compelling evidence that aggressive lifestyle interventions, including metabolic or bariatric surgery or marked caloric restriction, can actually prevent or even achieve remission of type 2 diabetes. Clinical trials consistently show metabolic surgery has greater efficacy than medical management alone in eligible individuals. These foundational changes are often the most impactful first steps.
For millions globally, insulin is not just a treatment, it's life itself. But what makes it so complex to administer effectively, differing fundamentally from how our bodies naturally produce and utilize it?
Insulin is indeed the absolute mainstay for virtually all patients with type 1 diabetes, and a significant number of those with type 2 diabetes eventually require it. Long-term chronic treatment predominantly relies on subcutaneous injection. The complexity arises because subcutaneous administration differs from the body's natural insulin secretion in two major ways. First, the absorption kinetics from the subcutaneous space cannot perfectly reproduce the rapid rise and swift decline of endogenous insulin in response to changing blood glucose levels.
Can't match the body's speed.
Right. Second, injected insulin enters the peripheral circulation, flowing throughout the body before reaching the liver. This contrasts sharply with physiological secretion, where insulin is released directly into the portal circulation, going straight to the liver first. This altered delivery route changes insulin's influence on liver function, making precise external dosing challenging. In terms of insulin preparation, modern human insulin is produced by recombinant DNA technology. Doses are expressed in international units. Most preparations are supplied at a standard concentration of 100 units per milliliter, U100. For patients with significant insulin resistance, more concentrated preparations are available, like U200, U300, or even U500 regular insulin, allowing for smaller injection volumes.
And the array of insulin formulations is quite broad now, cleverly engineered to tailor absorption rates and duration of action to better mimic natural patterns or provide steady basal coverage. How are these modifications achieved?
Exactly. Insulin preparations are primarily classified by their duration of action. We have very rapid-acting insulins, aspart, glucine, lispro, for meals, and longer duration formulations, degludec, detamir, glargine, for basal coverage, distinct from older NPH insulin. Modifications involve either slowing absorption from the injection site or altering the insulin's amino acid sequence to change its behavior. A significant clinical challenge is the wide variability in kinetics among individuals, and even with repeated doses in the same person due to absorption variability. Let's delve into specifics. Short-acting, regular insulin molecules associate into hexamers, slowing absorption, so it should be injected 30 to 45 minutes before a meal. Regular U100 can be given IV or IM, but U500 is for SC injection only.
And the short-acting insulin analogs like lispro, aspart, and glucagon were developed specifically to overcome that inherent slow absorption of regular insulin, right? Offering a quicker onset for mealtime flexibility.
Yes, these analogs were engineered precisely for that purpose. They're absorbed much more rapidly than regular insulin. Consequently, they should be injected 15 minutes or less before a meal, or even immediately after. They generally lead to lower rates of post-meal hypoglycemia and modestly improved A1C levels compared to regular insulin. Their modifications involve small amino acid changes that reduce self-association, allowing rapid dissociation into active monomers. For instance, Lispro reverses B28 and B29, Aspart substitutes proline at B28, glulazine substitutes at B29 and B3. For long-acting insulins, NPH insulin, insulin isophing, is a suspension of native insulin complexed with zinc and protamine. It dissolves gradually, SC, providing prolonged duration, usually given once or twice daily.
And then there are the newer long-acting analogs, which truly aim for an even steadier peakless profile, trying to mimic that constant, low-level basal insulin the body naturally produces.
That's where insulin glargine comes in. It's modified with arginine residues and a glycine substitution. It's a clear solution at pH 4.0. When injected into neutral pH SC space, it aggregates, leading to prolonged, predictable absorption. Because of its pH, it can't be mixed with neutral short-acting insulins. Glargine has a minimal peak profile, providing more predictable 24-hour coverage than NPH, usually once daily. It has a lower risk of hypoglycemia, especially overnight. Available as U100, U300, and biosimilars.
A big improvement over NPH.
Definitely. Insulin detamere is modified with a fatty acid added at LysB29. This allows it to bind reversibly to albumin SC and in plasma, prolonging its action. In type 1, twice-daily detamere has a smoother profile and reduced hypoglycemia versus NPH. Absorption is similar to glargine, but detamere often requires twice-daily dosing for full 24-hour coverage. Finally, insulin degludec is modified with throat-anolated at B30 and conjugated to hexadecanidioic acid. It forms multihexamers SC and binds well to albumin, leading to a very prolonged effect over 24 hours at steady state, associated with less severe hypoglycemia than glargine. Beyond these, stable combinations of short-acting and long-acting insulins are available for convenience.
There's even an inhaled insulin formulation, though it hasn't seen widespread clinical adoption. What's the story there?
Yes, inhaled insulin was developed. It has a more rapid onset and shorter duration than injected analogs, intended for mealtime coverage with a long-acting basal. However, it hasn't been widely adopted due to adverse events like cough, throat irritation, and crucially, it's contraindicated in smokers or those with lung disease due to potential pulmonary effects and variable absorption. Regarding delivery methods, subcutaneous injection is most common. Pen devices are popular, and newer smart pens can record doses and connect to CGM. Intravenous infusions are for acute situations like DKA or perioperative periods. Long-acting insulin should never be given IV or IM.
And continuous subcutaneous insulin infusion, CSII, often using an insulin pump, offers a very different approach, allowing for a more physiological delivery and precise titration. How does that technology work?
Right. Only short-acting insulins are used in insulin pumps. The technology provides a constant basal infusion, programmable for different rates, and allows bolus injections for meals based on carbs and current glucose. This enables a more physiological profile, especially during exercise, reducing hypoglycemia compared to injections. And the integration with CGM is rapidly evolving, with closed-loop or automated systems using algorithms to adjust insulin delivery based on sensor data, moving towards an artificial pancreas.
Beyond the type of insulin and the device, what are the practical considerations that affect how quickly insulin is absorbed after injection? How does this impact daily management?
Several factors influence absorption. The SOT matters. Abdomen is 20–30% faster than arm. Type of insulin, obviously. Subcutaneous blood flow increased by massage, heat, exercise increases absorption. Smoking, muscular activity at the site, volume and concentration injected, depth of injection, IM is faster than SC, all play a role.
Lots of variables.
Yes, that's why rigorous rotation of injection sites is absolutely crucial to avoid scarring, lipohypertrophy, fat accumulation, or lipoatrophy, fat loss, which can impair future absorption. When it comes to dosing, regimens often involve mixtures or, more commonly now, a basal bolus concept. This includes long-acting, basal, and short-acting bolus insulin for meals. Total daily dose, TDD, is typically 0.4 to 0.7 units a day in type 1. Obese patients, type 2 patients, and adolescents may need more, 1–2 units go due to resistance.
And how is that total daily dose typically split between basal and mealtime insulin? And how do patients fine-tune those mealtime doses for optimal control?
The basal dose is usually 40% to 50% of the TDD. The rest is prandial insulin. Mealtime doses should reflect anticipated carbohydrate intake using a carb ratio. A correction dose of short-acting insulin is often added to correct high pre-meal glucose. A single daily dose of long-acting is usually insufficient. More complex regimens with multiple injections are often needed. Careful monitoring fingersticks or CGM plus A1C guides dose individualization. For patients with gastroparesis, injecting short-acting insulin after the meal based on food consumed might be better. Adverse events? Hypoglycemia is a major risk. Always weighed against benefits. Modest weight gain, 1 to 3 kilograms, is common. Allergic reactions are uncommon. Lipoatrophy is rare now. Lipohypertrophy emphasizes site rotation.
Beyond daily management, insulin plays a critical life-saving role in acute, severe metabolic situations like diabetic ketoacidosis, or DKA, and in managing hyperglycemia in hospitalized patients. How is it administered in these unique, high-stakes scenarios?
In DKA or HHS, intravenous insulin is often preferred for rapid, precise control, though SC regimens are also effective for DKA. Insulin acutely inhibits lipolysis and gluconeogenesis and stimulates glucose uptake. Blood glucose falls about 10% per hour. Acidosis corrects more slowly. Glucose administration often becomes necessary later to prevent hypoglycemia while ketones clear. HHS patients might be more insulin sensitive. Fluid and electrolyte, especially potassium, replacement is crucial. When transitioning from IV, a long-acting insulin must be given SC before stopping the infusion to prevent rebound hyperglycemia. Hyperglycemia is common in hospitalized patients, over 30% in some centers, worsening outcomes. Often it's newly discovered stress hyperglycemia. Contributing factors include stress hormones, inflammatory mediators, medications like glucocorticoids, IV dextrose, fluid shifts, and altered tissue perfusion affecting SC absorption.
So insulin is truly the cornerstone here, regardless of the patient's severity. And what about the targets for glucose control in the hospital, as they might differ from outpatient settings?
Absolutely. Insulin is the cornerstone. Oral agents have limited use due to slow onset, variable absorption, and side effects in this setting. For non-critically ill patients, a basal plus bolus correction regimen adjusted for intake is optimal. Sliding scale regimens alone are less effective than scheduled insulin. For critically ill or those with variable perfusion, IV insulin is the choice, allowing rapid titration. Also ideal for perioperative periods and childbirth. Glucose targets are generally 140 to 180 mg/dL, 7.8 10.0 millimeter for most, possibly tighter, 110, 140 mg/dL or 6.1 to 7.8 millimol for some critically ill patients. Now, regarding children and adolescents, diabetes is a common chronic childhood disease, with type 2 rates increasing. For type 1, therapy involves intensive basal bolus or pump therapy, aiming for near-normal glucose control while rigorously avoiding hypoglycemia, the main limiting factor. A1C goal is 7%, maybe slightly higher for those with hypoglycemia unawareness. Pumps and CGM are increasingly used.
And for type 2 diabetes in children, how does that therapy typically begin, especially given its strong link to obesity in this age group, which is a growing concern?
For pediatric type 2, lifestyle management, weight reduction, and increased activity is the absolute first step. Pharmacologically, metformin is the only FDA-approved agent for kids as young as 10. Insulin is typically the second line if metformin isn't enough, starting with basal or moving to multiple daily injections. Response can differ in adolescents. Weight gain with insulin is often a bigger issue than hypoglycemia in pediatric type 2. From these foundations, let's explore the diverse arsenal of other glucose-lowering agents.
Beyond insulin, the scientific community has developed a truly diverse and expanding arsenal of medications that target different facets of glucose regulation, allowing for highly personalized treatment strategies. Let's break down these fascinating mechanisms one by one.
You're right, it's a dynamic field. Many agents act as insulin secretagogues, stimulating insulin release. This includes sulfonylureas, meglitinides, GLP-1 agonists, and DPP-4 inhibitors. Let's start with KATP channel modulators. Among these, we have sulfonylureas. Current ones include glyburide, glibenclamide, glipizide, and glympuride. Extended release or micronized forms exist. Glyburide is often avoided due to hypoglycemia risk and potential cardiac concerns.
How does sulfonylureas actually work at the cellular level to stimulate insulin release? What's the precise molecular mechanism?
Their mechanism is precise. They stimulate insulin release by binding to a specific site on the beta cell KATP channel complex, the ESSER subunit. This binding inhibits the channel, causing it to close. KATP closure prevents potassium efflux, depolarizing the cell membrane. This opens voltage-gated calcium channels. Calcium influx occurs, triggering insulin exocytosis. Acutely, they increase insulin release and shift the insulin-glucose dose response left, meaning less glucose is needed to trigger insulin release. For ADME, they're absorbed well GI, though food hyperglycemia can reduce it. Highly protein-bound, 90-99%. Short plasma half-lives, 3 to 5 hours, but effects last 12-24 hours, allowing once-daily dosing for some. metabolized by liver, CYP2C9, excreted in urine, use caution with renal or hepatic insufficiency due to accumulation risk, therapeutically used for type 2 diabetes, 50-80% respond initially. All seem equally efficacious. Secondary failure is common, where response diminishes over time, likely due to progressive beta cell failure. Interestingly, some monogenic diabetes forms, neonatal, MODY3, respond very well long-term, contraindicated in type 1, pregnancy, lactation, significant liver kidney issues.
What about the side effects and drug interactions, especially given that hypoglycemia is such a major concern with this class?
Hypoglycemia is indeed the major risk, potentially severe. Weight gain, 1 to 3 kilograms, is common, less frequent. GI issues, rare liver problems, jaundice, blood issues, granulocytosis, anemias, hypersensitivity, skin reactions, rare. Alcohol flush, hyponatremia. Cardiovascular safety seems neutral compared to other agents in recent large trials, resolving past controversies. Hypoglycemic effect can be enhanced by a reduced metabolism excretion or displacement from protein binding, sulfonamides, clofibrate, salicylates. Ethanol also enhances risk. Many drugs increase risk. Androgens, anticoagulants, azoles, etc. Conversely, other drugs decrease effect by increasing metabolism or inhibiting secretion. Beta blockers, calcium channel blockers, steroids, thiazides, etc. Interactions are numerous. Dosing, start low, titrate up. Longer-acting agents, glimepiride or micronized forms, allow once daily. Glipizide or glimepiride generally safer in elderly than laboride, but still use caution. Moving to non-sulfonylureas, meglitinides, repaglinide is an example. It also closes K-ATP channels but binds to a different site than SRR. ADME, rapidly absorbed, peak in 1 out, T12 1 out, rapid on-off, metabolized by liver, CYP3A4. Use cautiously in renal insufficiency. Side effects. Hypoglycemia, secondary failure. Interactions involve protein binding displacement or altered metabolism. Gemfibrozil, itraconazole.
And what about nataglanide, the other meglitinide? How does it compare and where does it fit into therapy?
Nataglanide also blocks K-ATP channels via a distinct site, promotes more rapid but less sustained insulin secretion than others. Its main effect is reducing postprandial glucose spikes. Dosing, 120 milligrams, 3x daily, 1 minute before meals. Metabolized by liver, CYP2C9, 3A4, use cautiously in hepatic insufficiency, some renal excretion, drug interactions, some reduce effect, steroids, thiazides, others increase hypoglycemia risk, alcohol, NSAIDs, beta blockers. May cause fewer hypo episodes than repaglinide due to rapid offset. Secondary failure occurs. Now let's move to biguanides. Metformin is the only one available. Fenformin and buformin were withdrawn due to lactic acidosis risk.
Metformin is so widely used as a first-line agent. What's its central mechanism of action, and how does it primarily lower glucose without stimulating insulin release or causing hypoglycemia?
The central action of metformin is reducing hepatic glucose production, HGP, mainly by limiting gluconeogenesis. Proposed mechanisms include effects on mitochondrial respiration, reducing ATP, increasing AMP, leading to activation of AMP-dependent protein kinase, AMPK. AMPK activation stimulates hepatic fatty acid oxidation, glucose uptake, non-oxidative glucose metabolism, and reduces lipogenesis and gluconeogenesis.
So it hits multiple pathways in the liver. Yes. Other ideas include inhibiting mitochondrial glycerol phosphate dehydrogenase, blunting glucagon effects, inhibiting lactated glycerol conversion to glucose, also appears to act in the gut. Key characteristics: mostly liver-mediated action, minimal effect on muscle sensitivity, little effect on glucose and normal glycemia, does not stimulate insulin release, rarely causes hypoglycemia alone, lowers glucose by reducing HGP, complements insulin action on the liver. ADME, immediate release usually twice daily, near 1.5-1.0 G, max 2.5 G, benefit plateaus 2 G. Sustained release once daily, 500 to 2,000 milligrams. Many fixed-dose combos available. Absorbed mainly from small intestine, 70-80% bioavailability. Peak 2 hours, T12, 4 or 5 hours. Does not bind plasma proteins. Excreted unchanged in urine. Relies on OCT12 for transport into liver kidney, MAD12 for excretion. Metformin is widely considered the absolute first-line treatment for type 2 diabetes. What makes it so effective, versatile, and often a preferred initial choice over other agents?
It's generally accepted as first-line, most commonly used oral agent globally. Effective as monotherapy and in combination. Safe and effective in gestational diabetes, though off-label in U.S. Efficacy is superior or equivalent to other orals. Reduces microvascular complications. Limited data suggests macrovascular benefit too. Does not typically cause weight gain, sometimes mild weight loss. Delays progression from pre-diabetes. Used off-label for PCOS.
What about the adverse effects, particularly the historical concern about lactic acidosis? What's the current understanding and guidelines regarding its safety?
Most common side effects, 10-25%, are GI, nausea, indigestion, cramps, diarrhea, due to direct GI effects. associated with lower B12 levels over time. Monitor. GI effects often abate, minimized by starting low, titrating slowly, taking with meals. ER form may help. Lactic acidosis, rarely reported, typically in patients with poor tissue perfusion, sepsis, MI, CHF. Causal link questioned recently. Renal failure is common comorbidity, reduced clearance, but recent studies in severe renal failure showed no increased rates.
So the thinking has evolved.
Yes. Current guidelines. Generally safe if GFR 30, MLMN 1.73 millishe2. Assess renal function before starting, monitor annually, discontinue if renal function might decline acutely, contrast die, severe illness. Contraindicated in severe lung, heart, liver disease, chronic alcohol abuse. Interactions with cationic drugs eliminated renally, cimetidine, furosemide. Next, thiazolidinediones, TZDs. Ligands for PPARO nuclear receptor, rosiglitazone and pioglitazone available, troglitazone withdrawn for liver toxicity.
How exactly do TZDs work at a molecular level to improve insulin sensitivity, and what are their primary pharmacological effects?
TZDs activate PPARO, mainly in adipose tissue, also muscle, heart, beta cells, macrophages, endothelium. Endogenous ligands are small lipophilic molecules. Activation causes heterodimer formation with retinoid X receptor, interaction with DNA PPAR response elements, changing gene expression. Principal response. Adipocyte differentiation promotes uptake of fatty acids into fat cells, shifts lipids from extra-adipose sites to adipose tissue. Consequence, increase insulin sensitivity. Pioglitazone and rosiglitazone increase insulin-mediated glucose uptake by 30–50%.
Significant improvement.
Yes. Adipose tissue seems primary target, but skeletal muscle likely plays a role too. Also reduce HGP and increase hepatic glucose uptake. Mechanism debated, direct tissue effects, indirect via adipokines like adiponectin, or both.
And what are their unique effects on lipid metabolism?
They reduce plasma fatty acids, increase clearance, reduce lipolysis, shift triglycerides from non-adipose to adipose tissue, visceral to subcutaneous fat. Pioglitazone reduces triglycerides 10–15%, raises HDL. Rosiglitazone, minimal effect on triglycerides, increases LDL, ADME, once daily dosing. Absorbed within 2–3 hours, unaffected by food, metabolized by liver, CYPs. Can use in renal insufficiency but not active liver disease. Drug interactions. Rifampin inducer decreases TZD levels. Gemfibrozil inhibitor increases levels. Dose reduced TZD. Onset slow. Maximal effects take 1 to 3 months. Therapeutically. Enhance insulin action, liver, fat, muscle. Improve glycemic control. A1C reduction 0.51–0.4%. Key feature. Reduce hyperglycemia without causing hypoglycemia. Require endogenous insulin, so not for type 1. Effective alone or added to metformin, sulfonylureas, insulin. Pioglitazone available combined with logogliptin. What are the most common and serious adverse effects of TZDs, especially concerning fluid retention and the historical heart failure concerns?
Most common. Weight gain, 2 to 4 kilograms first year, and edema. Due to increased adiposity and fluid retention. Insulin co-treatment doubles edema weight gain. Macular edema reported. Fluid retention is dose-related. Mild hematocrit reduction, heart failure. Increased incidence, up to 2-fold, with long exposure. Attributed to plasma volume expansion in at-risk patients. No acute effect on contractility. Use cautiously in compensated HF. Monitor closely with insulin. Should not be used in moderate to severe HF. NYHA 3 review.
There's also been a complex history of cardiovascular safety concerns, particularly with rosiglitazone. What's the current understanding?
Rosiglitazone. Past concerns of increased misstroke risk led to FDA restrictions, now lifted as later trials suggested neutral effect. Pioglitazone. Most evidence supports mild beneficial effect on overall CV events. Reduced stroke MI risk in some trials, including in non-diabetics. Other adverse effects. Increased bone fracture risk, mainly women. Consider osteoporosis risk. Liver. Usually lower transaminases, reduced fatty liver. Pioglitazone effective in NASH. Rare acute liver injury reported. Withhold if active liver disease. Now, GLP-1 based agents harnessing the gut-brain connection. We revisited incretins, GLP-1, GIP, stimulating insulin. GLP-1 receptor is a key drug target. Expressed in brain, too, reduces food intake. GIP receptor targeting is also emerging.
So GLP-1 and glucagon actually originate from the same precursor molecule, pre-proglucagon. How does that tissue-specific processing work?
Yes, from pre-proglucagon. Processing is tissue-specific. Pancreatic alpha cells make mostly glucagon. Intestinal L cells and hindbrain neurons make mostly GLP-1 and GLP-2. GLP-2 affects gut epithelium, setaglutide for short bowel. Native GLP-1 stimulates insulin, inhibits glucagon, delays gastric emptying, reduces food intake, normalizes insulin secretion. Critically, insulin effect is glucose-dependent, low hypo risk, but rapidly inactivated by DPP-4, T12, 1 to 2 minutes, so not useful therapeutically itself.
So to get around that rapid inactivation, scientists developed two main strategies. Mimic GLP-1 or protect natural GLP-1.
Exactly. Strategies: injectable DPP-4 resistant GLP-1 receptor agonists, GLP-1RAs, and these small molecule inhibitors of DPP-4 enzyme. 6 GLP-1RAs approved, albiglutide off market. Exenatide, synthetic exendin-4 Gila monster peptide, not metabolized by DPP-4, longer T12, approved for top 2, improves A1C 1%, causes weight loss 2.54 kilograms, extended release form, once weekly, even more effective. Liraglutide, long-acting GLP-1 modified with fatty acid chain, delays absorption, binds albumin, T12-13, once daily. Some DPP-4 protection, improved A1C, weight loss, titrate dose up, fixed combo with D-gludes available, dulaglutide, fusion protein, GLP-1 linked to IgG4-FC, modified for DPP-4 protection, T12, 5 days, inject once weekly, titrate dose, potent long-acting, modified for DPP-4 resistance and tight albumin binding, T12, 7 days, once weekly injection. Revolutionary oral formulation co-formulated with absorption enhancer, SNAC, allows daily oral dosing.
How do these GLP-1RAs compare in terms of their overall glucose-lowering efficacy and their truly notable effect on weight loss?
All effective as monotherapy, often recommended first line for certain profiles. Modest differences in potency. Semaglutide appears most potent. Daily exonated lixisenatide weakest. Significant weight loss across class. 3.5 kilograms in P2D, higher doses of liraglutide, 3.0 milligram, and semaglutide, 2.4 milligram, approved for weight loss in non-diabetics. 6 kilograms, 13 kilogram loss versus placebo.
And their impact on cardiovascular risk has been a major focus, leading to a profound shift in treatment guidelines. What have those trials revealed?
Absolute critical findings, all tested in large CV safety trials. Exenatide, lixisenatide were non-inferior, no added risk. Liraglutide, dulaglutide showed superiority, significantly reducing MEs, CV death, stroke, MI. Semaglutide oral injectable showed safety, conferred protection, superiority trials ongoing. Findings led to guidelines recommending GLP-1RA for patients with that high risk for CVD.
What's the shared molecular mechanism behind the broad actions of these GLP-1 receptor agonists?
All activate the GLP-1 receptor, class B GPCR, expressed on beta cells, CNS, heart, vasculature, kidney, lung, GI mucosa. Activation hits CAMP-PKA pathway, other signaling, PKC, PI3K, beta-arrestin, alters ion channels, beta cell effect, increased insulin biosynthesis, sexocytosis, glucose-dependent CNS effects, reduced food intake, delayed gastric emptying, nausea side effect, ADME, exenatide SC twice daily before meals, peak 2-hour, T12, 2-3-hour, renal clearance, weekly prep uses microspheres, lixisenatide T12, 3-hour renal clearance.
And the longer-acting one?
Liraglutide SC once daily, peak 8-12, T12, 12-14 hour. Cleared metabolically like large proteins. Dulaglutide and semaglutide extended T12 5 and 7 days, dose weekly, reached steady state in 1-2 months. No significant effect of renal hepatic impairment on their clearance. Adverse effects. Nausea vomiting common initially 30 to 50%, wanes over time, CNS mediated. Dose titration helps. Delayed gastric emptying may affect absorption of other drugs, OCPs, antibiotics. Hypoglycemia rare alone, increased risk with insulin, renal impairment. Exonated dilixisenatide avoid of CRCL 30 mLm. Gallbladder disease, risk increased with liraglutide. Pancreatitis, possible association, surveillance data, caution of history. Thyroid C cells, receptor expressed, avoid if personal family history of MTC or MEN2 based on rodent data. Now, dipeptidyl peptidase 4, DPP-4 inhibitors. DPP-4 is a protease that inactivates GLP-1 and GIP, found on endothelium T cells, CD26, circulating form. DPP-4 inhibitors block this enzyme, increasing active GLP-1 GIP levels after meals. Small molecule oral agents provide near-complete inhibition. Increase active GLP-1 from 10-20% to near 100%. Available.
Sitagliptin, saxagliptin, linagliptin, aligliptin, US, vildagliptin, EU.
So, by protecting the body's natural incretins, how do DPP-4 inhibitors achieve their glucose-lowering effects, and what are their overall clinical characteristics?
Mechanism. Allo, lina, sitagliptin are competitive inhibitors. Vilda, saxagliptin bind covalently. All lower DPP-4 activity 95% for 12-hour. Consequence: twofold rise in active GIP-GLP-1, increased insulin secretion, reduced glucagon, improved fasting postprandial glucose. Importantly, no direct effects on insulin sensitivity, gastric motility, satiety. Weight neutral. Monotherapy A1C reduction modest, 0.4%. Effective added to metformin, TZDs, SUs, additive effects, ADME, oral daily doses, absorbed well. Allo, saxa, sita, vilda circulate unbound, excreted unchanged in urine, dose reduced in renal impairment. Linagliptin unique. Protein-bound, cleared hepatobiliary, no renal dosage needed. Metabolism, only saxagliptin significantly metabolized, CYP3A4. Dose reduced with strong inhibitors, ketoconazole. Adverse effects, generally well tolerated, no consistent issues in trials. Cardiovascular safety, large trials for allo, saxagliptin showed CV neutrality, no increased MACE risk. However, saxagliptin showed small increase in heart failure hospitalization risk, FDA warning. Rare severe joint pain, reported FDA warning.
DPP-4CD26 on lymphocytes, complex immune implications, but no major clinical issues seen. Next, alpha-glucosidase inhibitors, acarbose, miglitol, reduce intestinal absorption of complex carbs, starch, dextrin, disaccharides by inhibiting alpha-glucosidase in brush border. Also increase GLP-1 release, secondary effect, ADME. Dosed with meals, 25, 50, 100 milligrams. Start low, titrate for balance of glucose control and GI symptoms. Acarbose minimally absorbed. Miglitol absorption saturable, 5100 fent, cleared renally, dose reduce of CRCL 30.
What are the main side effects, particularly the prominent gastrointestinal effects?
Most prominent. GI effects due to undigested carbs fermenting in colon flatulence, diarrhea, bloating, cramps. Mild liver enzyme elevation with acarbose, rarely symptomatic. Rare skin hypersensitivity. Hypoglycemia rare alone, possible if added to insulin interactions. Acarbose decreases digoxin absorption. Miglitol decreases propranolol absorption. Contraindicated in stage 4 renal disease. Therapeutic use. Adjuncts for type 2, especially postprandial glucose, combined with other agents insulin, reduce A1C 0.5 to 0.8%, fasting glucose 1 mg, postprandial 2.0, 2.5 millimeter, weight neutral, no significant lipid effects. Next, NAP plus glucose transporter 2, SGLT2 inhibitors, revolutionary class, canagliflozin, epagliflozin, or tugliflozin.
How exactly do SGLT2 inhibitors work, targeting the kidneys to lower glucose? Very different approach.
Unique mechanism. SGLT2 is almost exclusively in the proximal renal tubule. Reclaims 80 and 90% of filtered glucose back into blood using NA plus gradient. SGLT1 gets the rest. SGLT2 inhibitors block this transporter, promoting urinary glucose loss, glucosuria. They lower the renal threshold for glucose excretion from 180 mg/dL down to 50 mg/dL.
So you pee out the excess sugar.
Essentially, yes. Monotherapy. Reduce A1C 0.7, 1.0%, weight loss 2-4 kilograms, decrease BP 2-4 mg/g. Also used in combination, additive A1C drop 0.5, 0.8%, combos with metformin, DPP-4 inhibitors available.
What's truly revolutionary is their profound impact on cardiovascular and renal outcomes. Can you elaborate?
Game-changing results, all tested in large CVOTs. Empagliflozin and canagliflozin decreased EMA in high-risk T2D patients. Dapagliflozin and ertugliflozin were non-inferior, no added risk. Strikingly, all SGLT2 inhibitors significantly decrease hospitalization for heart failure. Dapagliflozin reduced HHFCV death and HFrEF with or without diabetes. Canagliflozin reduced HHF and T2D with nephropathy.
Huge benefits beyond glucose.
Absolutely. Renal benefits too. Cana, Dapa, and Pagliflozin each decrease regression of renal disease in trials of patients with reduced albuminuria. Guidelines now emphasize early use of SGLT2 inhibitors in T2D with CVD, HF, or CKD nephropathy, ADME. Good oral bioavailability, 60 to 80%, unaffected by food. Peak 1 to Hora, 90% protein bound. T12, 12 hours, once daily. Metabolized by glucuronidation. Inactive metabolites renally excreted. Parent drug not renally excreted. Tablets with 2 doses each.
What are the main adverse effects related to their mechanism, and what about those clarified early safety concerns?
Side effects predictable from mechanism, increased risk of lower UTIs, 2%, genital mycotic infections, 3 to 5% due to glucosuria. Mild diuresis can cause hypertension, dizziness, SBU elderly and diuretics. Potency decreases with worsening kidney function. Need GFR 30-45 depending on age and indication. Do not cause hypoglycemia alone, but can potentiate hypo with insulin. Early concerns. Fracture risk, Cana not borne out. Amputation risk, Cana warning now removed after further study. Euglycemic DKA can occur rarely as during illness surgery fasting. Mild transient initial dip in GFR possible, part of renoprotective mechanism. Other agents, pramlintide, amylin analog. Amylin co-secreted with insulin. Pramlintide is synthetic form. Acts via amylin receptor. Hindbrain Madlec. Do dose titrated lower for T1D. Cannot mix with insulin in the same syringe. Adverse effects. Nausea, hypoglycemia. SPO when added to insulin must reduce prandial insulin dose initially. Contraindicated in gastroparesis. Used as adjunct in T1D, T2D on mealtime insulin. Bile acid binding resins. Galesavelum approved for T2D. Mechanism unclear. Reduced glucose absorption. Bile acid signaling. Animal absorption. GI side effects common. Constipation, dyspepsia. Can increase triglycerides. Interferes with absorption of other drugs. Reduces A1C 0.5% as adjunct. Bromocriptine. Low dose formulation. Dopamine agonist approved for T2D. Mechanism modest. Likely CNS action. Dosed morning. Side effects. Nausea, fatigue, dizziness, orthostatic hypotension limit use.
Given the progressive nature of type 2 diabetes, it's rare that one medication is enough long-term. How do elite professionals intelligently combine these powerful tools, and what guides their complex decisions?
Crucial point. T2D pathology progresses. Most patients need stepwise intensification. Guidelines, ADA, EASD, exist, but no single consensus on combos order. Selection involves comorbidities, side effects, cost, A1C goal. Recent evidence supports early SGLT2 IGLP-1RA for high CV renal risk patients, regardless of A1C, grade study. Adding liraglutide or basal insulin to metformin gave slightly better, more durable control than glimepiride or sitagliptin. SGLT2I not tested.
So metformin and lifestyle remain the absolute initial foundation. What happens if glycemic control isn't met?
Consensus. Metformin plus lifestyle first. If target not met, e.g. A1C 7% and 2,3 NARDI. Add second oral agent. Additive effects. Fixed combos available. Or add basal long-acting insulin, covers fasting glucose, combined with oral agent, covers postprandial. Choice guided by estimated beta cell reserve, C-peptide, patient goals. Insulin often eventually required due to progressive insulin deficiency. Costs are a major issue. Treatment is expensive, multiple agents for diabetes plus comorbidities. Affects adherence, choices, newer agents costlier, older generics, metformin, SU, cheap. Insulin prices rising despite biosimilars. Cost-benefit debate ongoing. Shared decision-making incorporating patient circumstances is key.
It's exciting to see what's on the horizon. Where is this dynamic field heading in terms of cutting-edge research and potential future breakthroughs?
Very promising areas. Type 1. Immunomodulation, prevent block autoimmunity. Anti-CD3 antibody, delayed onset in stage 2. TXNIP targeting with K8 channel blockers showed promise in recent onset. Automated insulin delivery, closed loop artificial pancreas, rapidly progressing. Protein chemistry, multi-receptor agonists, GLP-1 plus glucagon or GIP for enhanced effects.
Dual or triple action peptides.
Exactly. Other type 2 therapies evaluated: glucokinase activators, 11 HSD1 inhibitors, GPR40 agonists, combined SGLT12 inhibitors, metabolic bariatric surgery, very effective for obese T2D, transplantation. Whole pancreas transplant can normalize glucose and T1D.
While hyperglycemia is the core challenge, the treatments themselves can lead to the equally dangerous extreme, hypoglycemia.
Critical point. Healthy glucose rarely falls below 3.5 millimibers 63 milli GDL due to counterregulation. Hypoglycemia is hazardous, potentially lethal. 3 common scenarios. 1. Diabetes treatment, insulin secretagogues. 2. Inappropriate endogenous insulin, insulinoma or IGFs, non-islet tumors. 3. Purposeful and inadvertent use of glucose-lowering agent in non-diabetic. First third can occur fasting or fed. Neoplasms cause fasting hypo mainly. Hypo most pronounced serious with insulin therapy. Causes with insulin. Dose too large, mismatch with food, increased sensitivity, adrenal issues, exercise. Major risk weigh against benefits of tight control, especially problematic in elderly. Body's counter-regulatory response. First, endogenous insulin secretion reduces 70 millijoule. Then counter-regulatory hormones release. Glucagon, epinephrine, norepinephrine, growth hormone, cortisol, all raise glucose. Symptoms onset 60-70 milli-GDL, 3.3, 3.9 millim.
And what do the symptoms feel like for the patient? How do they progress?
Usually autonomic first. Sweating, hunger, paresthesias, palpitations, tremor, anxiety, warning signs. Lower glucose, neuroglycopenic symptoms, brain glucose deprivation. Difficulty concentrating, confusion, weakness, drowsiness, warmth, dizziness, blurred vision, loss of consciousness. Severe hyposeizure, coma. Deficient response in long-term diabetes. Glucagon response often fails. Depend on epinephrine. If that fails too, increased severe hypo risk, central to hypo-unawareness autonomic neuropathy, detection via monitoring, sleep hypo, hard to detect, morning headache, night sweats, mild moderate treatment, oral glucose, 15 to 20 gram carb, severe fiforium glucose or glucagon injection.
For severe hypoglycemia, when oral glucose isn't an option, what are the critical rescue medications and how have they evolved?
Glucagon is critical. Single-chain polypeptide. Acts via GPCR on hepatocytes, GSCMP, PKA, rapid glucose production, glycogenolysis. Prescribed for at-risk individuals, train family friends. Used when patient can't take oral glucose and IV not available. Older kids. Lyophilized powder, needed mixing. Delay confusion in emergency. Administer 1 milligram SIM, SC, IM, most common emergency route. Onset 5-10 minutes, max 15-20 minutes. Short-lived effect may fail if glycogen depleted. Give oral glucose after response. Nausea, vomiting common, 30-40%, 10-20%.
But the landscape for glucagon has significantly changed recently with new, easier-to-use preparations.
Huge progress. 3 new preps. 1, nasal formulation, single-use device, dry powder, comparable efficacy to IM, superior ease of use in simulations. 2, Liquid formulation, native glucagon and DMSO. Auto-injector prefilled syringe, identical kinetics response to kits, but much easier, faster, more successful use. No mixing. 3. Glucagon, analog. 7 substitutions, improve solubility, stable liquid formulation, prefilled syringe auto-injector. Similar pharmacodynamics. All share GI side effects, nausea, vomiting, but prove convenience is major advance.
We've mostly talked about stimulating insulin and counterregulation. But what about a drug that actually inhibits insulin secretion?
That would be diazoxide. Antihypertensive antidiuretic with potent hyperglycemic action orally. Mechanism. Interacts with KATP channel, prevents closing or prolongs open time. Opposite of sulfonylurias. Inhibits insulin secretion. Dosing 3-8 millibiricol a day, adults, kids. 8-15 millikilo a day. Infants, give divided doses with meals, nausea, long T12, adverse effects, napless fluid retention, hyperuricemia, hypertrichosis, thrombocytopenia, leukopenia, limit use. Therapeutic use. Despite side effects, useful for inoperable insulinomas and children with neonatal hyperinsulinism. Finally, somatostatin. Natural hormone from delta cells, GI tract, CNS, inhibits many endocrine secretions, TSH, GH, gastrin, insulin, glucagon, etc. Acts via SSTR15 GPCRs. Physiological role unclear. Short T12, 36 minutes, prevents direct use. Longer-acting analogs, octreotide, lanreotide, pasireotide. Useful for severe secretory diarrhea, carcinoid tumors, glucagonomas, vitellipomas, acromegaly, Cushing disease. Chronic use, adverse effects, gallbladder issues, stone sludge, GI symptoms common.
Wow, what an incredible deep journey we've taken into the intricate world of diabetes and glucose regulation. From the delicate dance of glucose homeostasis and the molecular machinery of insulin secretion, to the diverse arsenal of pharmacological therapies and the critical management of hypoglycemia. We've truly gone deep today. You now possess an elite-level understanding of this complex field.
Indeed. We've seen how every detail, from the precise chemical modifications of insulin analogs to the nuanced mechanisms of action of different drug classes, plays a vital role. It's a testament to the body's extraordinary complexity and the ongoing dedication of medical science to improve patient lives.
What stands out to you from today's deep dive? Perhaps it's the astonishing number of counter-regulatory mechanisms your body employs, or the surprising ways unrelated conditions or medications can impact glucose levels. Maybe it's the profound shift in understanding type 2 diabetes as a heterogeneous syndrome, or the critical importance of a multifaceted approach to its management.
Right, and this deep dive really makes you consider, given our increasing understanding of diabetes as a heterogeneous syndrome with distinct patient clusters, how might future therapies evolve beyond our current broad classifications? Will treatments become even more precisely tailored to an individual's unique pathogenic mechanisms, essentially, a move towards precision diabetes?
Our goal with the deep dive is to give you that unfair advantage, that shortcut to truly being well-informed, not just about the headlines, but about the underlying science, the clinical implications, and the fascinating future of medicine. Thank you for joining us on this deep dive. Until next time, keep learning, keep questioning, and keep exploring the fascinating world around us.